Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you all for being with us today for our upcoming session. For the last 2 years, in a partnership with Arnold Ventures, Health Affairs has published a series of articles on Forefront addressing the topic of integration between Medicare and Medicaid for people duly eligible for those two programs. We're really proud of the content that series has produced, and we're now excited to be able to supplement the content with this event. We'll be focusing today on a topic that always comes up when we talk about these two programs, which is how do we really take the terms of integration and coordination and give them meaning, particularly meaning for the people that the program is designed to serve, rather than just treating them as abstract goals or as perpetual problems. We're going to talk about what it really means to integrate and coordinate, and how we can set a course for a better program for dual enrollees. We have a really terrific panel today. I'm going to very briefly tell you who they are, give you a few more introductory words, and then we'll jump right in. You're going to hear today from Laura Keohane, an associate professor in the Department of Health Policy at Vanderbilt University. Olivia Richard, an advocate at the Camden Coalition. Crystal Vardaman, managing principal for Medicaid policy and programs at Aurora Health. Dennis Heafy, a researcher in the Disability Policy Consortium and a commissioner of MACPAC, the Medicaid and CHIP Payment and Access Commission. Kelly Emmons, Senior Strategic Integration Advisor for the Department of Social and Health Services in the Aging and Long-Term Support Administration for the state of Washington. And Brandon Wilson, Senior Director for the Center for Community Engagement in Health Innovation at Community Catalyst. A number of our panelists have been authors of Forefront pieces. Particularly, I want to call out Laura, who has been one of our lead contributors, and we appreciate that, but we have benefited from perspectives from many of you. So I can assure the audience that you're going to get a variety of perspectives and very deep expertise regarding this important combination of programs. As we start, I'm going to ask each of our presenters to just take a few minutes, introduce themselves, explain to you where they fit into the dual eligible ecosystem, and to offer up some thoughts about what is most important in achieving the goals of these two programs. We'll then move into a discussion. I have a few topics and themes I want to get through. We intend it to be a discussion. If you're watching us live, you can submit questions through the Q&A box at the bottom of the screen. Please keep your questions relatively succinct, and if you get them in early and they're of general interest, I think they'll be of general interest to the audience, I'll do my best to include them in the conversation. So without further ado, as I say, we're just going to have our panelists start off one by one and say a little bit about themselves and what they think are the most critical issues facing the program and the populations it serves. I'll turn Laura first over to you.
Thank you, Alan, and thank you for having me today. I am a researcher based at Vanderbilt University's Department of Health Policy, and most of my research deals with how Medicare and Medicaid policies can improve quality of care and reduce barriers to access for low-income Medicare and Medicaid beneficiaries. I've had the pleasure, as Ellen mentioned, of authoring several of the Forefront pieces on dual eligible beneficiaries with my co-author, Anne Huang. The points that I wanted to raise today relate to how do we build off of the choices that dual eligible beneficiaries and states have already made when it comes to delivering Medicare and Medicaid benefit. For dual eligible beneficiaries, depending on how you count integrated care, we know about 10 to 20% of dual eligible beneficiaries are now in some sort of integrated product, whether it be an integrated dual eligible special needs plan, whether it be a product offered under the financial alignment demonstration, or whether it be in a PACE program. However, 10 to 20% is a relatively small share of the dual population, and how do we ensure quality of care for the rest of the dual eligible beneficiaries who are not choosing integrated product? We do know that a lot of dual eligible beneficiaries are choosing to be in managed care plans that are not necessarily integrated, either just plain vanilla Medicare Advantage plans or dual eligible special needs plans that are not integrated with their Medicaid programs. And one of my concerns is that we might be focusing too much on intensive regulation of integrated products at the expense of protecting overall quality of care for dual eligible beneficiaries, regardless of what plan choices they're making. I think the steps that we can take to simplify choices for dual eligible beneficiaries and for low-income beneficiaries and make sure that they're getting access to high quality of care, regardless of what product they're in or regardless of what plan they're in, have the potential to significantly reduce barriers for beneficiaries. I think one promising step in that direction that CMS finalized this fall are measures like taking steps to make it easier for low-income beneficiaries to enroll in Medicaid in the first place. And if they're navigating the process of, for example, signing up for Part D low-income subsidy benefits, also making it easier for them to enroll in Medicaid at the same time. So I think the steps that we're taking in those directions, making processes easier for dual eligible beneficiaries, have the potential to significantly improve quality of care. I also want to recognize the choices that states are making when it comes to improving quality of care. So we know that when states did decide to pursue an integrated option, most of them were choosing a more flexible option, like contracting with special needs plans, rather than signing up for the full financial alignment initiative demonstrations. And I think that reflects the significant number of resources and bandwidth that is required to overhaul Medicare and Medicaid benefits in a significant way. I think one of the downsides of the ongoing end of the financial alignment demonstration is that we have lost the formal mechanism for states to be funded for reducing Medicare expenditures. So that was one of the big upsides of the financial alignment demonstration, that states were finally being recognized in a financial concrete manner for doing more coordination of Medicare and Medicaid benefits. And I think with the loss of the financial alignment initiative, we don't have any sort of policy stepping in its place to provide that type of incentive for states to do this work. So I think if we really want to move the needle on increasing access to integrated benefits, we have to provide the resources for states to do that, both for upfront cost of overhauling Medicare and Medicaid benefits and making a lot of design decisions, and also having some sort of permanent mechanism in place where states can share in the savings on the Medicare side, where there's the specific significant potential in terms of reducing hospitalizations. So I will close there, hopefully under 5 minutes.
Great, thank you for kicking us off with some very concrete areas that we'll have a little more time to focus on as the conversation continues. Olivia Richard, I'll turn next to you.
Hi, my name's Olivia Richard. I am an advocate for disability rights with the Camden Coalition. I got hooked up with them through my work with Commonwealth Care Alliance and the Center to Advance Consumer Partnership. I was actively involved in Massachusetts setting up the first iteration of what is called One Care, which is their dual special needs plan, which came out of the financial alignment demonstration. I think one of the biggest things I can emphasize to anyone is that the little things are the big things to consumers. If they can't get access to a ventilator circuit that's clean because of a policy barrier, that's an issue. If they can't get access to medication that is the type that they need, i.e., like if there's brand exemptions or favoritism in policy, that's a problem for that individual. But that stacks on to the plan when that individual has complications or has issues. as a result of not being able to get what they need. Thank you.
Thank you, Olivia. And I think we'll have good opportunity again to weave that into additional discussion, but I appreciate you kicking us off with that, what sounds simple, but very important principle here. Crystal, over to you.
Sure. Hi, good afternoon, everyone. I'm Crystal Vardaman, and I'm a managing principal at Aurora Health Group. We are a mission-driven national health policy consulting firm working with state and federal clients, foundations, and others to advance access to affordable, comprehensive, equitable, and high-quality health coverage and care. Prior to Aurora, I was a policy director at MACPAC, the Medicaid and Chip Payment and Access Commission, and I worked at the Government Accountability Office before that. So I really come to this work now as a partner of groups implementing programs for this population, but with a background that's more from an analytic, evaluation, and oversight perspective. And I wanted to center my opening remarks around some of the things that I think are important factors to consider as we talk about building programs to support better care for dual eligible individuals, really around the complexity of players involved in serving this population, the importance of stakeholder engagement, and the importance of considering equity in everything we do. So first, in regard to the complexity of players and removing silos between them, of course, whenever we talk about dual eligible integration, we're clearly talking about, removing silos between Medicare and Medicaid broadly. But when we think about this population and its heterogeneity and needs, there's just many players involved. So one of my particular areas of interest is around home and community-based services, and that's, of course, used by many dual eligible individuals. And there we have Medicaid, where it's not just one thing, one entity, but there's also various waiver administration agencies that are involved, like aging and developmental disability services. And so, how those HCBS benefits are going to be carried out has, more players involved than just the Medicaid agency itself. There's, of course, many managed care plans involved in different states, and also a variety of other programs that serve people's needs, like housing supports and supported employment services, food security programs. So there's a lot of different players that have to be brought to the table to really address all of an individual's needs in a person-centered way, and I'm sure we'll get more into that today. And then, of course, part of breaking down those silos is around robust stakeholder engagement. So some colleagues at my firm, for example, work with California's Department of Healthcare Services in implementing exclusively aligned enrollment dual eligible special needs plans. And some of the great deal of work there has been around finding channels for DHCS to receive stakeholder input, to inform policy in a real way, to get buy-in, to gain trust, and to really have ongoing communication that can address issues that arise and drive improvement in the program. And then, of course, regarding equity, something that we should really consider in everything we do. I know Brandon's here from Community Catalyst. I saw that they released a report this week on HCBS equity issues for dual eligible populations that was really driven by interviews and focus groups. And those findings really revealed some unmet need and issues around limited access to culturally and linguistically appropriate HCBS services. So while it's very unfortunate, of course, to hear about these poor experiences that people have had with the healthcare system, we need more of that kind of work to give us some direction and feedback on where we need to focus our attention to address those problems. And so, of course, with as much detail and consideration to the, again, diversity in this population as possible. So with that, I look forward to the conversation today, and we'll turn it back to you, Alan.
Thank you, Crystal, for kicking us off that way. And of course, I got to work with you when you were at MACPAC, so it's nice to have you here again. Dennis, over to you.
Thank you. My name is Dennis Heaphy with the Disability Policy Consortium, a Massachusetts disability rights organization in Massachusetts, and I could echo just about everything everyone else has said so far. I'm a dual eligible enrolled in OneCare, just as Olivia is, and have been engaged in the advocacy work on OneCare since 2011, I think, prior to the start of OneCare. At one point in my life, I worked for the Massachusetts Department of Public Health, so I know how hard folks in the state work. Now I am the co-chair of the OneCare Implementation Council. The council was created through the advocacy of disability advocates in the state, and it serves as a means of providing guidance and the development and the implementation of OneCare. I have to say, as an advocate, as a dual eligible, I really am exhausted. In Massachusetts, there are only 3 plans, but they all share in common shift in definitions of care coordination, increased reliance on AI-driven utilization management practices that don't align with the person's real-life experience or needs, restrictive determination of need policies that differ between plans, constant changes in provider networks, and some of these changes resulting from providers receiving reduced payments, delays in payments, or denials, unnecessary burdensome authorization requirements, and administrative denials. If I one message to policymakers, or to actually one would be, for me, I think the goal of the DSNP should be equity, equity by race, ethnicity, linguistically, but also between folks with disabilities in the general population. By reducing disparities, I believe that the states will be sure that they're getting their money's worth. And the other is to build trust with the disability community and develop partnerships with the disability community. This takes time. It's not something that's easy. It took quite a long time for the disability community to develop this trust with Mass Health, but we've done that. And so it's not a transactional relationship we have. It's actually a very meaningful one, and one that's really, we think, and I think the state would echo this, has really supported and strengthened the OneCare program. And so I would say if regardless of differences between states, for SMACs to be stronger, they require the support of the disability community in pressing for contract requirements such as uniformity in data collection to ensure apples to apples comparisons between plans, and advancing health equity, investment in upstream interventions such as HCBS and social services, ensuring that there actually is continued emphasis on rebalancing spending, and that so we don't lose that part of the financial alignment project, and that we look at integration as well as coordination, and that UM processes need to be transparent. People need to understand why decisions were made, how they were made, and they need to know how to actually to make it appeal, so that we can reduce the number of folks who don't appeal decisions, because that's low appeals rates is an indication of something being wrong with the system. I will leave it at that, and thank you.
Thank you, Dennis.
I just one last thing, and I think is that as when OneCare began, no plan wanted to enter into this market. There were plans were concerned about not making money off of it, and now we see a real investment in the dual space, in the integrated care space, and so there's concern now about the emphasis of these entities really being about financial profit, not necessarily being about person-centered care and outcomes that the state and consumers want. And that's the last thing I'll say for now. Thanks.
Great, thank you. Kelly, let me turn over to you.
Thank you, Alan. Good afternoon, everyone. My name is Kelly Emmons. I'm the Senior Strategic Integration Advisor for the Aging and Long-Term Support Administration in Washington. And that is the entity responsible for long-term services and supports. My role within our agency is to work on integration models and initiatives, primarily focused around care coordination for complex populations as well. So my team manages the Health Homes Dual Demo Program, PACE programs, and are advancing Medicare and Medicaid integration initiatives. We do this work in partnership with our Medicaid agency, And I think that partnership gives a unique lens to the work that we're doing to integrate care in Washington. And I think one of the important points that I would make for this conversation today is we talk a lot about integration, integrating funding streams, integration models, but we don't do enough talking about coordination across silos and systems. And integrating financial models is only integrating financial models. It is not ensuring coordinated care across different delivery systems or even within a single delivery system. A lot of the focus of my team and our integration efforts in Washington are both, let's look at the integration models from a funding perspective, but then let's also look at the way that care is delivered across the different systems and get into the details and the weeds, which is the critical part of integrating care and coordinating care. So I think one takeaway for me that I would like, folks to hear is that contract language and policy are great, but the devil's in the details. And it really takes talking to the people that you're serving and creating delivery systems that meet the needs of individuals. I think I'll pause there.
Great. I know we will follow up on that topic, so thank you. Last, just for introductions, and then we'll move into the discussion. Over to you, Brandon.
All right, thank you, Alan, and thank you, everyone. I certainly like to echo all the comments that were made by others, but I'm Brandon Wilson. I am the Senior Director of the Center for Community Engagement and Health Innovation at Community Catalyst. We are a health advocacy organization that really do believe fundamentally that healthcare is a right for all, and we work vigorously in pursuing that goal alongside one of our national, state, local, tribal partners and advocacy coalitions across the U.S. And we believe that the way to do that, and I believe this from the beginning, is in order for health systems and for decision makers to be held accountable to community, that community and those who are most impacted have to be at the forefront of decision making, including those who've been historically underserved, disinvested communities, and even those who've been, frankly, harmed by the status quo of our healthcare delivery system. For us, that means making sure that we prioritize their voices in decision making. That means making sure in an enrollment landscape that people have access to information, and information in a timely manner, information that's congruent with their health literacy levels, with their language preferences and needs. I'll make this very real and plain. My mom is duly eligible for Medicaid and Medicare. And just last week, I was home, and all year long I've been calling. So my mom will have the renewal letter come from the Medicaid office. We're in the PhD unwinding. And thankfully I was at home because a neighbor brought the letter over because it was addressed to me and not her. And it had the wrong address. And thankfully we lived in a small town where they knew she as well as myself. And thankfully they had enough conviction to bring that letter to us. When opening it and trying to go online to help her navigate selecting her coverage and the way to renew it, I got thoroughly confused. The D-SNP plan that she has was not an option on the Medicaid plans that you could choose from. I called the plan said, well, you should just guess. You should just pick it. If it's us, just pick the one that has us. As though that was the answer, which clearly there was no coordination between the state and certainly this particular plan. When using that default option to just guess, then all the dental coverage, none of them align with what her current dentist or dental plan is. So all I have to say, if I consider myself fairly educated in this area, if I was thoroughly confused, I can imagine what it is for people who depend on these services every single day, who do not have the expertise, privilege, or background that I bring to this work. And I will close in that his response to me was, well, it's self-explanatory. Well, if it were self-explanatory, I probably would not have made the call. So all that just to emphasize that when we create programs and policies to actually benefit people, when we involve people in that design, then we won't have to have so many of these examples of uncoordination. And making sure that we can give people the trusted resources, the accessible information that they need when they need it, so that they can have the coverage that values their lives. Thank you. I'll pass it back to you, Alan.
Thank you so much. So thank you all for those opening thoughts. And as I said at the outset, I'd like to sort of work through a few themes and bring you all in however you're it'll be a conversation. That's what I want it to be. So the first theme, and it came through, loud and clear, is the importance of patient engagement. But I want to push the theme because I know there's no disagreement in this group about its importance. But I will say, I worked in Massachusetts many decades ago, and we often hold it up as sort of the exemplar of the kind of trust and partnership, Dennis, that you mentioned. But not every dual lives in Massachusetts. And I'm not saying everything's perfect in Massachusetts, but it does seem to sort of capture a lot of what's there. So I wonder if we could sort of broaden out our lens and help people in states and state officials in other states. And Washington, of course, has a long, very positive history around long-term services and supports. So what are give us a little bit more concrete sense. What are the institutions? What are the mechanisms? What are the starting points? If you don't have an infrastructure, what are the first things you want to do? Because Olivia, as you said, the small things are the big things. The only way you learn the small things is by listening, because the policymaker would never know about them if they weren't listening to people who experience them. So could we just get a little conversation going about how do you start this in a way to build up to the level of listening and engagement that you all have said is so important? Who wants to start me off here? Kelly.
I'll put myself out there, and then people can tell me what we're doing wrong too. As we've worked to improve our long-term care system and our coordination on duals issues, right? So primarily our LTSS service recipients are duals. So I'm going to talk about this both from the lens of trying to improve duals integration and the work we're doing in our long-term care system, because they kind of come together. But about 5 years ago, our agency put explicit effort into including service recipient voice into our policy making, and that landed on my plate. And I struggled at first. I'll just acknowledge that it's hard from a policy perspective when we're very used to having policy conversations and we talk in a way that doesn't make sense to people who aren't in this world. And so as we started to try to figure out how to engage with service recipients, we really struggled to talk to them in a way that they could hear what we were saying, and it didn't feel like we were just doing PowerPoint presentations on stuff that they weren't really connecting with. We had to do a lot of thinking about and educating of people that were coming into that group about how to present. Nobody cares about every administrative code or federal regulation that is attached to this policy. They want to know, how does it impact them? And so we really had to be thoughtful and listen, because when we would present PowerPoints, nobody would say anything. Nobody would give us any feedback. They would just thank you and move along. when we started shifting the way we were talking about it and asking them to build the agenda, we would, do an exercise of what are the critical things to you, and then we would ask them to prioritize, and we would present on those topics, not from a policy perspective, but from a, here's the services available, here's what the letter might look like, here's what might be confusing. We started to get like a very different kind of engagement. And then the next challenge comes with, okay, now that people are engaging with us and you're building trust, how do we incorporate that? How do we get our policymakers, our leaders to actually hear this input before they've already made the decision? And I'm going to tell you that we're not perfect at this by any means. But this is the experience that I've had in trying to navigate. I think this is something that we are trying to continually do better. We just started paying our service recipients for their time to come talk to us, which we're very, very proud of. They should be paid for their time and their lived experience. But it's hard from a policymaker perspective to shift the way you think, slow down, and take the time to listen to what can be difficult feedback. It's a little bit humbling to listen to people give us feedback. So I'll pause there and let others have space.
Well, first, I want to thank you for your willingness to put yourself out there and describe that this is hard work and it doesn't come easily, and you get things wrong. So people often don't want to acknowledge that. So I want to recognize the importance of starting at the point of saying you're not sure. What other insight? I thought that was terrific. Any other insights people want to share on first steps or resources? Love to hear other perspectives on this.
And sure, and I'll talk about the mistakes we made from the disability advocacy side. We got out ahead of the demonstration, and we went statewide, started talking to the disability community around the state, asking them, what do you want? This is what's happening. What do you need? And state officials came to those meetings. And so there's actually a shift in power dynamic where the state was listening to what people need rather than the state saying, this is what we're going to be providing. And that radically altered the contracting and also the expectation of how plans are supposed to be doing things. And so integrating things like independent living philosophy principles into how decisions are made, integrating the recovery model into how things are done, and also using those as bars for measuring the quality of the services and how decisions are made by the plans. What we did not do well, because the disability movement is often too often overrepresented by white folks, particularly in Massachusetts, and that we did not do enough outreach and inclusion of folks from ethnic minority populations. And so right now, as the state's developing its MAC, it's put out a contract, and we're hoping that disability advocates and a group called Healthcare for All and others, we can come together and build that intersectional bridge between organizations that serve immigrant populations, African American populations, who may be underserved in the Medicaid and Medicare space, particularly folks with complex care needs, and look at what are the needs, where the gaps in needs. So it's not just the voices of white folks in the disability community. I would also say that that includes going to homeless shelters, to recovery communities, asking people on the ground, what do you need? And I'm a big follower of Kamara Jones. I really think that unless you do things creatively and address the upstream services that people need, that the downstream costs are going to be much higher. And so, it's about the SNP population not being a population, but being a diverse set of populations, each with distinct needs. And unless those needs are taken into consideration, the plan is not going to succeed. People are not going to join the plan because the trust is already not there. And the only way to build that trust is to engage that voice.
Thank you. Brandon.
Yes. One, I'd like to say that one thing that we do, and Crystal mentioned it, is we try to have a lot of listening sessions and focus groups so that we can hear directly from beneficiaries and individuals on how programs and policies are impacting their lives and the care that they receive. In a similar event, I remember, and maybe I'll put myself out there as something that I learned per se. It was a convening that we were holding at Community Catalyst last year, and I was moderating a panel discussion, and I asked a question from one of the panelists. I think we really understand the school to prison pipeline, but can you help me understand and help the audience understand the connection between the criminal justice system and healthcare? And his answer has profoundly changed my approach to this work. His response was that we, in these wonky environments, that we see these as various different systems. To people who actually live everyday lives, it's just one nexus of systems that can be oppressive and that can be harmful to them. So to the Crystal's point that she made earlier, yes, we talk about Medicaid and Medicare, but it's a whole host of systems that come into play that can be harmful to people's lives, or if we do it right, that we should and could be actually helping people's lives. When people really in their life, they don't really see themselves as duly eligible beneficiaries of Medicaid and Medicare. They see themselves as people who need health coverage, who may also be grappling with housing and economic stability and family dynamics. And I think the question is, how do we design our systems to coordinate the care that they need in the ways that they need it across these systems that should be serving them? So I think that's where listening comes in, and active listening and slowing down on how do we create these and redesign systems so that they are accountable to communities.
Crystal, I hesitate to put you on the spot, but I'm going to anyway. I guess I assume that you're brought in typically by the state. Is that fair? I'm just trying to think of, I'm reflecting on Dennis's idea of flipping the power dynamic, which of course I love. The idea of that, but that requires, having enough power to exercise and flexing it. And I guess I assume that in most states, this sort of begins with something more like what Kelly described. The state says, gee, we're not doing as well as we'd like to. We need to be creative here. Maybe we could listen some more. But I love the thought of the genesis of this coming directly from the people rather than from the state. Although I think we should take it no matter who's starting the conversation.
Yeah, and that's where I was thinking was that, the state has resources and partners to get the ball rolling and to really develop an infrastructure around engaging with, the community, that how you implement that can hopefully get to Dennis's point about, how to really get meaningful input. And as I reviewed some of the articles from the series, I'll just raise one of them up, how states and health plans can meaningfully engage duly eligible individuals in plan governance, which was Sarah Triano, Courtney Roman, and Henry Claypool's piece. And they put out a nice framework, which I think gets to a lot of this around the differences between guidance, input, like implementation input, and then plan governance. And so, it sounds like we've been talking a lot about, how to get from particularly implementation oversight towards more real plan governance and, that ongoing, more deeply embedded feedback and really being a part of the decision making, which is, I think, something that, a lot of states are doing in many ways and plans and whatnot, but a place we can always continue to do more for.
Well, I'm going to bring in another theme, and it doesn't mean we need to leave this one behind. But I think, Crystal, you actually teed it up in your opening comments. Brandon, you just referred to them moments ago. We have so many different entities, enterprises that need to be part of this system if we're going to address people's needs. And what I'd like to sort of get going is a bit of a conversation about who those actors are, what they need, where we think they're doing well, where we think they're falling short. So we begin with the term duals and we say, well, Medicare and Medicaid need to, obviously they're relevant, and that means, the federal government, the states, but then we bring in health plans, we bring in the role of providers, we bring in the role of consumers, and then, Brandon, you open the door to completely other parts of the system that as you note, these are just people saying, it all looks like the government to me. Why don't you get your act together and try to help me out here? So we have this whole continuum, and now Dennis, I'm going to push you to repeat what you said in our planning call that you said maybe you wouldn't say, but but I'm going to push you anyway, which is, which of these institutions have the mindset and the incentive to invest in the kind of infrastructure that is needed for success, and what are some of the other approaches that these organizations can take that might be counterproductive or harmful to having the kinds of systems that we need. So I just want to broaden out to sort of the question of who are the players we need involved, who's doing pretty well, who needs more resources, help, and what would that look like to build the totality of a coordinated approach to supporting people who are dually eligible. Who wants to? Dennis, please.
So one of the concerns we have is the influx of venture capitalist dollars into the system, and whether those venture capitalist dollars are looking for short-term return on investment or actually looking out for the long-term needs and investment of the state and folks who are dually eligible. And so I'm just spacing the last part of your question, Alan. I don't know why, but it's making sure that the plans we found, this is just that when the investment of the plans is actually local, and local rules, local regulations, local contract requirements are in place that reflect the priorities of the state, that is a much better way of going about things rather than having a one-size-fits-all model that an insurance company might want and say, well, this is the way we do it in all other states, so this is the way we're going to do it in this state. And so it's really important that the models of care reflect the culture of the state. I'd say also to make sure that there's transparency in how the SMAC is created, and ensuring that CMS is an actual partner in supporting the states to protect their rights as well as the Medicare dollars, that there needs to be reinvestment back into the state, ensuring that the plans are not providing unnecessary services to people, but providing the services they actually require, so that states are not losing money, but are actually getting the investment that they need. And that's not the most articulate way of expressing that, but it's ensuring that the plans are transparent, and that the utilization management processes are transparent, and that decisions are based on what people need and not on a profit driven basis.
So before I let you go, I appreciate you jumping in, but let me just push a little bit. So we often hear one size doesn't fit all, but can you give a little texture to that comment? Because I do think there is often, particularly where we're worried about quality, there's often a push to have federal standards to assure that things go, that patients are protected. And so there's a tension between having federal standards and saying, but we need to tailor locally. And often it's the plans who are saying we need uniformity because they want to operate, one set of rules. So help us, and Olivia, I'd love it if you would think about this too. Give an example of a place where it has to be different, or it has to be aware of and incorporate what's happening on the ground, or else you're kind of missing the boat and you're getting things wrong. Olivia, do you want to jump in?
Yes, I'd love to jump in.
Okay, please do.
I think that some of the places where a one-size-fits-all policy just doesn't work is an example would be wheelchair standards. You know, what's covered, how often can people get repairs, things like that. I live in the Northeast. We're exposed to all kinds of road salt and cold and things. Our chairs are going to be exposed to a lot more stuff. So, you know, we may have a repair standard that's a little more aggressive than, say, California, where it's nicer. I love Boston, but let's get real.
Oh, that's very helpful. It gives some, as I say, I wanted just an image, and that's a great image to have. And Dennis, I don't know if you want to expand on this as well.
Thanks, Alan. I think it's moving away from patient language to person language, because what so many folks need are social services, upstream services that are not medical. People need access to housing. They need social supports to remain in housing, like low threshold housing. So there needs to be investment in these types of services. And so that's not a one size fits all approach. There are states that are more rural than urban. And how do we make sure that the needs of those states that are more rural are met? In linguistic makeup, there's just so many ways. One size fits all does not work when we're talking about someone who's got a dual diagnosis of a mental health and a physical issue, or a substance use disorder, and also mental health, or folks who actually have social supports near them, and folks who don't have social supports near them. Like my family lives all around the world, New Zealand, all over the country. So I actually don't have supports near me. And so one size fits all would say this person gets X number of PCA hours because of their level of disability, all those sorts of things. They need this diagnostic code to get X, Y, or Z, and to move away from that sort of that system to one that's more organic. And particularly if we're going to address racism and the impact of racism on the system, and we see how it impacts access to HCBS and other services. So I think that the one size fits all is not going to work. But the federal government does have a role in ensuring that there are minimum standards in place in terms of how plans are investing to ensure there is rebalancing and spending taking place. And maybe to the chagrin of folks on the Medicare side, is reinvestment of Medicare dollars into the state when the state's really saving the money on hospitalizations, and they're losing money because they're investing in community-based services.
Great, thank you. Okay, so I feel like I have a much clearer picture of what some of that content was about. I want to try to also resurface this question of infrastructure. We spent some time in the first theme sort of around state and advocacy infrastructure and systems that include those voices, but I wonder if we could move into plan capacity, not just sort of the financial motivation, Dennis, that you mentioned, and providers. Are there things we need to be doing for or expecting of providers to build out a more robust system of care here? Or let me just back up and say, I think the reason I ask this question is that when I think about the policy discussion, it often goes back to, well, this is Medicare, Medicaid integration, and their health plans, which is where it happens. And like, those are the only three things that matter. If Medicare understands it and Medicaid understands it and the plan understands it, then everything's going to work great. I don't think it works that way. I don't think most of you think it works that way, but I do think there can be sort of sometimes a mechanistic approach like that's what integration is, right? It's Medicare, Medicaid, and the plans. So I was hoping you all could give a little bit more of a robust sense of what it really takes to achieve the kind of coordination that we ought to be able to do.
So I am so glad that Kelly is on the call representing Washington, because I think when we talk about integration, we often default to talking about managed care when many states still don't have Medicaid managed care for long-term services and supports or dual eligibles and are still relying on a fee-for-service system. So I think, we need to have a conversation about how we provide integrated care in a fee-for-service model, which I think Washington has demonstrated can be done and can be done successfully. So that is one starting place that I would say is that, we don't necessarily need to have plans. We need to have an approach that also thinks about how we can provide it outside of managed care plans.
Yeah, and Laura, I just want to kind of tack on to what you were saying, because I think just to broaden on that, a lot of times when we hear integration, we hear fully integrated as the gold standard, meaning everything's in managed care. But in Washington, we have a fee-for-service long-term care system that's ranked second in the nation. And to me, it is about how we integrate care without always having to integrate service delivery. So one of the things that we're working on, in our financial alignment, we look to our community-based organizations who are trusted in their community to deliver care coordination in a conflict-free way, not attached to a plan. And we're now trying to bring that into our dual special needs plans to say it's your community-based organizations that know these communities, that have the resources. Don't do everything in your plan. Don't, learn how to contract with small organizations. I think when managed care comes in, it's very scary for providers who are not used to that system, and community-based organizations who are delivering a lot of the social supports that Dennis was talking about earlier get left out of the picture for larger, national corporations that can be contracted. And I think one thing that we could do is build more infrastructure to support community-based organizations, to bring them into this fold, teach them how to contract, learn the business acumen that it takes to work with managed care plans. And from a state perspective, the discussion, to Laura's point, most states couldn't do fully integrated managed care, even if they wanted to. They don't have the infrastructure. And so I think we limit states' ability to move forward when we just talk about it in that language. There's a lot of things that states can do if we broaden the way we talk about it to improve the way that care is integrated across systems.
So I want to stay here for a little while, because I feel, and my last theme gets more into policy, but I feel like we've started the evolution in that direction. But as someone who's been working on issues around dual eligibles for a few decades, I have been struck by the evolution of what's the solution. And part of what we know, of course, is that there is no one solution. But I do think in Washington there's a tendency to have an image of what the solution is. And Laura, I go back to your comment at the opening that we're putting a lot of attention on the 10%, and we should be figuring out how to advance those integrated models at the 10%. But most of the people are not in that. And so thinking about what are the elements, the dimensions of successful provision of services, identification of need for patients and enrollees, that is not just figuring out who you're supposed to write a contract with, figuring out what the financial terms are, and handing it over to them and saying, do a great job. So I just want to push you all, because I feel like you have an opportunity to speak to a policy audience here. Talk about the role of the community organization. Dennis, you gave, and Olivia, you both gave examples of where national policy wouldn't work, but that that could be a government policy, that could be an insurance company policy. It doesn't matter whose policy is, it's still not going to work. So let's talk about the role and the provider. Kelly, you talked about provider trust and prepare and being, you know, able to navigate risk contracts. Like I'd love to get some more of the texture here that I'm afraid the policy audience often just sort of lets go. So say some more. Brandon, I think you wanted to jump in.
Oh, I'd love to jump in here. I'm gonna make three points here. The first is you'd asked the question earlier, and I think it's related here as well, around capacity and even with the provider community. I think it's very clear to us all now that we're facing an extreme shortage in healthcare workforce, as well as public health. And I think we can turn to community for solutions here. I think community have been drivers in showing us how to complement the healthcare workforce in ways that's meaningful to them, by way of community health workers, by way of doulas, by way of dental therapists and peer recovery specialists. There are ways that we can expand upon some of these community-driven approaches that can complement what's been the traditional healthcare workforce. I was speaking to someone just last week who was telling me at one hospital that they have 15,000 patients who they cannot assign to any particular primary care provider. And if they did to existing providers, they would likely leave. Secondly, around, you'd mentioned different entities, particular payers. We really have been speaking directly to beneficiaries and trying to understand what coordinated care for them would look like and what some of their challenges and what some of their solutions. One solution that's come loud and clear to us that's been given by beneficiaries is the need for a federal resource hub where there's coordinated information. CMS has the statutory authority to lead on that. We can bring in and make sure there's leveling of information and shared information in clear language, not just with Medicaid and Medicare. We could bring in plans here. We could bring in other trusted providers, such as family caregivers, such as SHIP counselors, such as community-based organizations. We hear even from SHIP counselors and navigators that the information is so disparate, it's very difficult for them to use information to help individuals navigate enrollment in a way that's meaningful and valuable for them. And lastly, I would lift up the plans in a very unique and good way. And that's one, I think the plans have been really good in trying to implement on CMS requirements around enrollee advisory councils. I think we're hearing a lot of good work coming from there. To that, I would flip that coin right back to CMS and ask if CMS, feds, or states are also employing similar practice of having enrollee advisory councils or CABs to inform their work versus simply requiring the plans to so. And lastly, I would say that whether we're calling it FIDE snaps or any other fancy language that we use, I think what's important to beneficiaries, I recall in one focus group, we were talking to a Medicaid recipient in California. And what the beneficiary said was that she doesn't, whether she continue to talk to her provider and get her same services, whether her transportation and prescription will be there. If none of that changes, she's completely happy. But she's, as far as whether she's enrolled in Medicare or not, she doesn't know, doesn't really care. They're not so concerned about the back operations as much as they are about how well the infrastructure actually serves them. So I think, lastly, in closing, I think some things that we can continue to push for, no matter what the entity is, of course, making sure there's true stakeholder involvement, making sure that there's really some standards in place. So no matter if you're getting to I think it was, don't remember if it was you, Laura, who made the comment, or if it was Kelly, but who made the comment that only 10% of dual eligibles are receiving care in integrated care products. But I think the question is in the details, and do we have clear standards to where no matter where a dually eligible person is receiving their coverage, that they can be guaranteed a certain level of quality? Are there certain safeguards that we can put into place, such as ombudsman programs, such as making sure that we have caps in place, such as transparency, so that we know what each of these plans really entail, so that they are meeting the needs of people.
Right.
Great, thank you.
I just
Dennis.
want to jump in after Brandon and say, people also want to go to the organizations they trust on the ground. If someone's a Haitian immigrant or an immigrant from Cambodia, whatever it may be, that plans and the state may find it, they may say it's a burden to actually contract with these organizations, but to get the results that they want and to get the buy-in and actually the involvement of the community in the plans, they need to do this. And I think one of the solutions is actually the value-based purchasing possibility, because these organizations don't have the capital to enter into risk ventures with plans. And so how can plans actually enter into value-based purchasing contracts with these plans that they're not required on, FTE is the full-time employee ratio that they're going to X, Y, and Z, but look at the outcomes they expect, look at the services they're hoping to receive, and set different types of benchmarks with these organizations to ensure that quality is happening, but not to use the fee-for-service model. I mean, they, at least like within these large integrated managed care organizations, the idea is to move away from the FFS and to move towards a more holistic approach to contracting that's going to result in better outcomes and reduce hospitalization rates and ED visits, which we didn't see in the FAI. And that's one of the reasons why we're in the DSNP world that we're in right now. And so how do we shift how things are done with the SMACs so we don't end up with the same results in the DSNP? So I really do think it's a lot of engagement with, it's the plans, even though they feel more comfortable with the idea of building internally, that investing out into the community and buying the services, as uncomfortable as that may be, because they may lose some control, that they may see a change in the results.
I'm going to bring in a couple of questions, and then I'll turn sort of to my third theme. But one question we got from the audience that I think I'll just pretty much read it verbatim, because I think they capture the thought very clearly. Health plans often discuss the fragmentation of dealing with many community-based organizations, but in markets where there are several managed care plans, the CBOs can be dealing with their own problems of fragmentation, duplication across the plans. So the question is, are there any models to tackle that and provide coordination among multiple plans? And I'll just broaden out the question to say, you all talked about the importance of engaging with community-based organizations. Is this a challenge you hear about? And any thoughts on the topic would be useful. Kelly?
Yeah, I definitely hear about this from both sides, from the plans and from community-based organizations. When we implemented our health homes model in a DSNP, one of the biggest challenges was the language, right? Like we speak different languages, and the contracting. So community-based organizations had different needs than the plans did. And it took a lot of conversations about how a community-based organization would submit billing, what the contracting terms would look like. I mean, detailed conversations, what the IT infrastructure requirements would be for these organizations, how they would share data. So from the community-based organizations, we had those challenges. From the plan side, you know, the plans have a very regulated environment, and to allow providers or non-traditional providers to take on things like care coordination program require a look at regulations and how risk was being mitigated. And so I think from both sides, there are challenges. I believe that they can be overcome, but they are hard conversations. We've done it. We've done it on a small scale. You would have to do it on a much grander scale to achieve, you know, wholesale change. But I guess I think coming into the conversation with the recognition that it's hard on both sides, from a plan perspective and a community-based organization perspective, and finding a way to meet in the middle is how we continue to move the mark and make sure that communities are included, even as we are shifting to a more managed care landscape.
Yeah, and I'll just echo that, you know, in our work with states, it's a fine line to walk, because, you know, states to some extent can try to make templates, make, you know, standardized policies and procedures so that, you know, there's one way to do things, but also wanting to give, you know, plans a certain amount of flexibility as well. And so, you know, I think some of the times the states we work with, they look to standardize what can be standardized, what feels right to standardize, while, you know, sorting out what you want to give more flexibility to the plans on.
Kelly, your comments remind me of a paper we published in the last couple of years. I'm going to try to find the site before this ends, although I'm not sure I'm that capable. I've got some folks helping me. But we had a paper on exactly this issue, that community-based organizations, health plans just speak different languages. And when you say, oh, yes, let's contract and figure things out, you know, you're dealing with separate cultures. You might say you're dealing with Medicare and Medicaid as separate cultures, but elevated even farther. And so I'll try to find that link and put it in the chat if I can, but it's something we've published on. I did get another question about sort of, are there, well, I'm going to actually sort of weave together two different questions, because equity has come up for a number of you in different ways. And I think it's important to focus on, but then the question is how to operationalize it. And so one question had to do with whether there should be specific requirements regarding closing disparities before plans can, you know, receive funding or profits or something like that. Another one of the questions had to do with whether, how do we set appropriate performance measures for different subpopulations when their starting places are different? So I realize those are two pretty different questions, but I just put out there the topic of how to address this. And then I think after this, I do want to sort of move us squarely into some policy questions before we run out of time. Anyone want to talk about approaching the equity issue and some of the practical steps to assure that we're moving that agenda forward?
Yeah, I can comment on this one, Alan.
Great.
I saw a related comment, so I'll speak to the equity one, which I think is really practical. Whether you're talking about, and this is no attack at them, but whether you're talking about social vulnerability index, area deprivation index, or some of the other deprivation indices, what's strikingly missing from them to me is the root causes. So if we're going to talk about the area deprivation, I'm going to pick on my city, Baltimore. It's difficult to look at just the median housing income without taking into context hypersegregation. It's difficult to talk about housing crowding without talking about redlining. Unless our vulnerability indices are really measuring what some of the root causes are that actually drove some of this in the first place, I think we could be actually shifting resources into areas who are not really experiencing some of the deprivation in areas that the indices can truly measure. For example, there was a paper that came out earlier this year that showed that one of the indices showed there was no deprivation in Washington, D.C. And the main reason was because that the median housing value was much higher in DC than most places in the country. So all that to say, I think there are ways that we can be a little more precise with equity and with equity measurements if we're trying to get to true equitable outcomes in these communities.
That's great. That's very helpful. Well, I think given that, yes, please, Dennis.
Concrete example would be the state identifying along with the plans and advocates goals that they want to work on together to address a disparity or inequity. It may be let's talk about disparity, make it easier in rates of folks who are put in nursing homes, skilled nursing facilities for short-term stays. And if there are disparities in numbers, if there are more African Americans, to reduce that number of folks to ensure they've got the HCBS services in place to get there. And so that's something everyone can work on together. How the plans do it would be up to the plans, but measuring it would be looking at the reduction in the number of folks who require that stay in the short-term SNFs. Or another one is a very medical one, but looking at diabetes and the rates of amputation among African Americans, and looking at are the plans reducing amputations in certain populations? I mean, that's an extreme one, but seriously, like everyone coming together and say, what are the ones that are impacting our state most and dual eligibles, and how can we work together to identify and address these? And how the plans do it, it's up to them, but then they get measured by that on how they succeed.
What I really like as you described that is that we started with sort of, as Livia said, the small things are the big things, and that's very much listening to individual enrollees about what is meaningful to them. And then, Dennis, you're describing a situation where you listen to collectively to the community and say what's important to you, and measure and pay on the base of that, as opposed to, again, some sort of national quality metric standard, which may be nicely validated but may not be the priority. Well, look, as we get to the last bits of our time, we're a policy journal, and we've talked about many different dimensions of policy, but at the end of the day, there is this federal legal regime, one called Medicare, one called Medicaid, that set sort of the overall parameters for all of the topics we've discussed to play out. And I'd love to hear from each of you, if you have an answer, or as many of you who do, when you look at where we are today, what would you see as the most ripe area for policy to advance? Acknowledging that there's a lot more than policy that we need, but it is a critical component. So who wants to take us straight into the realm of policy? Olivia, please.
I think from my perspective as a dual eligible who receives home and community-based services, making Medicaid the only payer for home and community-based services is not working very well for everyone, basically. If we can get Medicare to get some skin in the game, and if we can get policy implemented that can expand coverage for home and community-based services in other plans as payers, that would be extraordinarily helpful.
Great. Thank you for getting the policy discussion going. Who else wants to jump in? Laura?
I think I'd like to pick up where Olivia left off and think, a lot of the framework of improving policy for dual eligible beneficiaries has focused on the idea of, if we just improved the financing mechanism and got Medicare and Medicaid aligned, then improvements would naturally flow from there. And maybe, in honor of the discussion of flipping the switch, maybe we think about it of, there are specific pain points that we know are problematic for beneficiaries. Olivia originally mentioned wheelchair access. We know that is, durable medical equipment is an area of incredible frustration for navigating Medicare and Medicaid benefits, regardless of whether you're in managed care or traditional Medicare or fee-for-service Medicaid. We know it's hard to navigate long-term services and supports, and whether we want to start thinking about are we initiatives that maybe instead of trying to do improvements from the top down, maybe identifying areas that we already know are pain points and working from the bottom up to try and figure out, once we identify a specific goal, who are the people we need to get into the room? Who are the organizations we need to get in the room? How can we carve off some of the pain points and address those without necessarily figuring out how we redo the entire Medicare and Medicaid financing situation for duals, especially when we have states that have varying bandwidth and capacity to address these issues.
Great. Who else is ready to jump in?
Sure, I will. And just to piggyback up a couple of comments, I think, a couple of the things that come to mind. One around, I think Brandon mentioned a need for centralizing and sharing resources so that, states can learn about different strategies. And I think particularly thinking about the states that don't have managed long-term services and supports, what are some of the models, again, like Washington, that they can look to and how they can tailor, different strategies to meet their needs. And then thinking broader as well as in terms of resources to support states in planning and sustaining programs, looking over at HCBS and how states have been using the American Rescue Plan Act funds. We've seen so much creativity and so much energy around, investments in workforce and supporting family caregivers and, diverting people from institutions. And, so I know folks like MacPac have suggested more resources be brought to states to support planning and implementation. And I think that's been a good example of when you have resources to match that energy and those ideas that, states have been able to do a lot. So what can federal policy do to continue to support dual eligible integration here as well?
Great. It's been great. I'm ready for more.
I mean, from a state, yes, funding to support integration would be super helpful. Not just speaking for my state, but most of the folks doing dual integration in states are Medicaid folks. We are typically in the Medicaid realm trying to figure out Medicare. And that means that it takes a lot of bandwidth. And so I think I would just second and third the suggestion that that we would need at the state level support to improve integration. I think the other thing that I would say from a state who hears a lot of conversations about this gold standard of fully integrated care being the only true integration, I think we really need to shift that. And Laura, I like the point that you made around let's address the pain points. And if there's an integration model that can address the pain points in a state and deliver more holistic care, isn't that a better integration model than the one with a special name? So I think just talking about this more broadly, I know it's hard, it's super complicated, so we tried to put it in boxes, but I also think that makes it challenging for states that don't fit into that box to engage in the conversation.
So I'm just going to put a little exclamation point behind this. I mean, there are plenty of people who spend their entire professional careers studying or working in or advocating around Medicare. And there are people who spend their entire professional career studying and advocating, implementing Medicaid. And in order to get coordination integration right, you have to have a level of knowledge of two programs that are so complex that you could spend your whole life on them. And then we say to enrollees in the two programs, not you figure out what's Medicaid's part in this, what's Medicare's part in this, when, of course, as Brandon and others, but as Brandon particularly noted, that's just not how people live their lives. And we have created a level of complexity here that is somewhat overwhelming. And sorry to keep going here, but I also think we have to remember that in those worlds of complexity, in the policy community, there is often a desire for a simple solution, which is to hand it to an organization with aligned incentives to have them figure it all out. And it turns out that that's not exactly the solution. It doesn't mean it can't be part of the solution in some instances, but it doesn't solve the problem. And so I think we need to be creative. And part of what I like about the conversation we've had today is we've seen a lot of creativity about how many different ways you have to come at this, other than just saying, well, let them do it and give them the right, as you said, Laura, give them the right incentives, let them do it, and everything will work. And it's just that has not turned out to be the answer either. Okay, that was a long editorial comment. Any other thoughts, please?
I agree with you. I agree with Kelly. I think, and Laura, we shouldn't default to DSNPs as the answer to everything. I mean, for me, maybe a conflict-free care coordinator within a PPO system might work better for me and my needs. Maybe another model where it's more of the on-the-ground health organizations coming together, and they're the ones that are coordinating the services and contracting with medical providers rather than the other way around, where the plans are doing. So like I think we need to look at this more creatively. But just I think there needs to be policy about ensuring that there's that plans get what they need in order to develop and implement tools, programs, whatever they look like. Because we know that there's people out there where there's one or two people in that office who are Medicaid experts for that state, and they don't understand Medicare, and so it's unfair to them, and it's unfair to the beneficiaries to expect them to come up with something that's creative and is going to meet the folks' needs. I think something else in this, Brandon mentioned this, is we need a policy in place that holds CMS accountable to consumers. There needs to be some sort of a committee or a council nationally representing consumers as this is being implemented, and then finally a policy about setting a bar for states in what consumer engagement looks like, because CMS has put out guidance, but it really doesn't have measurements tied to that on what the expectation is on what that engagement actually looks like. And there's a lot of frustration on the part of advocates around the country who say that they're not engaged, that the state has like checked off, yes, we met with them, yes, and yet there has not been true engagement. And so I would like to see a policy in place that's really looking at the measures, what consumer voice looks like, and hold states accountable for that, just at the start.
Okay, Brandon, I think I'm going to give you the last word here.
Yeah, thank you. I think that Dennis teed me up well. If I can just go back to the Federal Resource Hub, I think the federal government is really well resourced to bring all the important entities and stakeholders together. So that I think some of us have mentioned like some of the low-hanging fruit or pain points. Like we know we can invest resources in personalized assistance. This is something that beneficiaries have asked for and that they want. we know that we're all equally confused with the misinformation, disinformation, lack of information. And I think just providing a space where all can access information on their own terms in ways that's helpful actually also addresses power imbalances and help to level the playing field. So that it is the community who can drive some of these wonky conversations versus technical experts who are talking at community. Then we can have true meaningful engagement, to Dennis' point, and not just check boxes. I think it's also a way for us to make sure that we have neutral and unbiased folks who are helping to navigate, and we're actually bringing the full ecosystem of stakeholders, whether that's family caregivers, whether those are health plans, whether those are SHIP counselors or CBOs. So I think that there's a very macro level solution there, but I think that there's some micro or at least meso level immediate action that we can take by simply listening to people who depend on these programs.
Great.
If I can just,
It's gonna have to be quick, Dennis, because I've got to let people out on time.
I want to give a shout out to policymakers, because I have a chance to talk with a lot of policymakers around the states, and they are working their butts off to try to do the best they can with limited resources. I also want to give out to I'll say his name specifically, Tim Engelhardt and his group in CMS, who are struggling mightily to bring all this stuff together in a way that really has folks who are dual eligibles at the forefront of their work. So I think it's important to say thank you to the folks that are engaged in this.
Well, I'm glad I didn't cut you off for that. So thank you, Dennis. Well, speaking of thank yous, I want to thank Arnold Ventures for supporting the series and today's event and for elevating this issue that's so important. I want to thank our panelists for just a terrific conversation, the variety of perspectives, the thoughtful responses. It was really a pleasure to be able to have this discussion with you. To our audience, thank you for your participation and coming. We do have an upcoming event I want to make sure you know about on Tuesday, October 24th. We have a professional development session on writing about racism in healthcare. It will feature Health Affairs editor Jessica Bylander and two authors from our October issue who wrote narrative pieces on the role of racism in the care that they've received. We're pleased to have been able to open today's briefing to everyone with support from our ventures, but we do also offer a program called Health Affairs Insider, which provides exclusive access to content beyond the journal. And if you become an insider, you will have access to events, newsletters on priority policy topics and other activities. Please keep an eye on our website. Go to healthaffairs.org/events to sign up for the newsletter and to be notified of additional events as they are announced. So again, with thanks to our terrific panelists here and for all the insights you provided and for your ongoing contributions to the Forefront series. With that, we are adjourned.